listening to Affect Autism, where affect is the #1 tool we use in supporting child development through playful interactions. Welcome back, listeners. I am Daria Brown. This is the We Chose Play podcast from Affect Autism. This week I have Erin Forward, a speech-language pathologist and certified lactation counselor at Cincinnati Children's Hospital. She's part of their interdisciplinary feeding team and their outpatient setting. Erin has advanced training in pediatric feeding and swallowing disorders, early language, AAC, alternative and augmentative communication, and trauma, specifically for medically complex children. And she's a DIR advanced floor time provider and a TBRI, or trust-based relational intervention, trained practitioner. She is also the regular co-host of First Bite podcast with fellow SLP Michelle L.W. Dawson, which I will put a link to in the blog post for today. Welcome, Erin.
Thank you. Thanks for having me.
We also have Taylor Anderson, who is a pediatric speech-language pathologist who is passionate about neurodiversity affirming care, interdisciplinary collaboration, and play-based intervention rooted in relationships. Taylor is a basic DIR floor time provider and a TBRI trained practitioner as well. Taylor is in Tampa, Florida, and our topic for today is DIR floor time in medically complex children, based on Erin and Taylor's recent presentation at the 2024 DIR conference in New York City this past March. Welcome, Taylor.
Thanks for having us. We're excited to talk about this today.
I'm so excited to have you guys on. I know trauma is such a huge topic, and there's so much information out there in the last few years. It's been really in the forefront. I liked that you guys relate this specifically to medically complex children, and I thought it would be a great topic to bring to the podcast.
So our focus of trauma-informed care, which very much aligns with floor time, is connecting with a child, giving them autonomy, building collaborative goals, and doing that all in this mindset of being very much aware of what a child has been through up until that point, what systems they've been involved in, who's a part of their care team, and making sure everybody is on the same page.
Mm-hmm. And you can't have trauma-informed care without also being neurodiversity affirming, because that is a culture, that is an experience that somebody has, and you have to acknowledge that as well. So Taylor and I were going through training for trust-based relational intervention at the same time that we were going through training with DIR floor time. And so we started to see these parallels between the two philosophies and how well they were integrated, both with our autistic patients, clients, and our medically complex clients. And so that was something that we really collaborated on, had a lot of conversations on, learned a lot from each other as well. And so that's been, we both use both of these frameworks with all the children that we work with.
And I also want to point out that a lot of people don't realize that DIR floor time, the developmental individual differences relationship-based model, is not meant specifically for autistic children. And in fact, when it was created, Dr. Greenspan was working with children in poverty that had developmental challenges. So it's really a model that is about understanding development and relating, communicating, etc. So I love that you find it helpful with another population too, and brought that up. I have seen Cincinnati Children's Hospital because it's right by Entertainment Junction, which my son loves, went to so many times over the years, and it's so colorful and inviting.
Mm-hmm. Yeah, I mean, I think in any hospital setting, you have to overcome some possibly traumatic experiences that a child has already been through. So there's a lot that I try to do as a clinician to help a child feel safe in a setting that is likely to maybe be traumatic for them after, most of the clients I see right now are both in the hospital and after they've been discharged. So trauma-informed care is really, really important for me to know, because I don't know everything they've been through in the hospital, but I know that being inpatient is very traumatic in and of itself. There's a lot of research on medical trauma and post-traumatic stress disorder that happens from those experiences. So I try to be very mindful of that and create as much safety as I can and acknowledge the trauma that they may have been through with both them and their caregiver.
So, as a parent of a child who went through medical trauma, I thank you for that. When my son was 28 months old, he had a grand mal seizure and another one 12 hours later. We were in the hospital for 4 months. He was only two and a half, and I slept there with him every night for 4 months. And we were in, intensive care, and then the hospital for sick children in Toronto for 3 weeks, and then over to Holland Bloorview Kids Rehabilitation Hospital for 3 months until Christmas time in 2011. And it was absolutely grueling as a parent, of course, watching your child be attached to IVs and not understanding why. And, he did get, I forget what it was called now, it's so long ago, but they gave steroids to sort of calm down his autoimmune reactions. So on steroids, it's really hard. He's twisting around and squirming, and then getting all of his, cords caught, and then numerous IV changes and blood drawn and band-aids and just like, I never wanted to see him go through anything again. So even now, if we have to give him vaccines or he needs any kind of tests, it's just horrifying. And to this day, if he sees a band-aid on anybody, he freezes in the moment and he looks at them and he says, "What happened to your arm?" or "What happened to your finger?" or whatever. And he will not ever let us put a band-aid on him. So I can imagine that when you talk about trauma, you're probably talking about, but let me know, are you talking about with medically complex children? Because I mean, in that rehabilitation hospital, I saw them all, lots of different medically complex children. And then, of course, in follow-up over the years, you see all of the different scenarios. Are you talking about trauma that they've experienced specifically, like I described, like in the hospital due to medical procedures? Because I know, like, trauma as a larger topic can be about a lot of different things, like, family upbringing issues and things like that.
The thing that you learn when you go through training specifically for trauma-informed care, that it's all encompassing, and there's no, the term sometimes people will use like big T trauma, which may be those big experiences that are part of the ACEs that children have been through. But the understanding that Taylor and I have learned through our training is that all trauma is valid, all experiences are valid. There's no measurement of what trauma is worse than another trauma, and we don't have control over the way our body reacts to trauma. So, I use a metaphor of a tree when I talk about trauma-informed care, neurodiversity affirming care, and I view trauma as the rings of the tree. We may not always see it. It may not always be disclosed to us, but I'm going to go into working with any child or family, assuming that there is some sort of trauma, and I'm going to engage in trauma-informed care to support them, because they don't owe me that. They don't owe me their vulnerability, but what I owe them is coming into that situation with not wanting to re-traumatize them with that vulnerability. When it comes to medically complex children, I know there's a big T trauma. So I'm also going to be attuned to the caregiver and the child with the understanding of that, and not pushing them too far when I first get to know them, because I don't know where their boundaries are.
And you mentioned ACEs. Can you tell the listeners what ACEs stands for?
ACEs stands for Adverse Childhood Experiences. So this could be anything that a child has experienced in their childhood that has impacted them in a traumatic way. And Erin made a great point that we really can't separate these things from medical trauma. And I also wanted to mention, you were talking about your experience with your son, and a big part of trauma-informed care is taking into consideration the entire family's experience. And that's important to keep in mind with any kind of trauma, that we're not just treating that patient or that client, we're treating the whole family. So we're always trying to keep in mind that connection with the caregivers that are on that journey with that child and are also experiencing their own trauma. And making sure we're keeping that in our awareness, and building goals and engaging in therapy that's reflective of that. I think oftentimes we see goals being placed and a child's plan of care that might be relevant to this physician or based on this benchmark, or but if you get to know the family and you engage with the child, it might not be relevant to them. And so what are we doing? And that's where Erin and I talk a lot about autonomy and helping a child discover what their individual interests are and what their goals are and what their family cares about, and tying it all back to that. And I think that's important to keep in mind with any kind of trauma.
There's a lot of studies that talk about the number of ACEs a child experiences and how it can affect their mental health. You know, you're more likely to have, you know, mental health differences as you get older, to have some of those experiences. And that's why the goal, which I think is, you know, is very much a goal of DIRFloortime, is felt safety. And Karen Purvis, who developed trust-based relational intervention, talks a lot about felt safety. And what that means is you may know a child's safe. You may know something's not going to happen to them. You may know that the triggers or, you know, what they've been through is no longer, they may not be in the hospital anymore, but similar to your son, if a Band-Aid makes him not feel safe, then that's the important factor in there. And we need to therefore consider the child and the family's experience, like Taylor was saying, because that's where that safety comes from. And that's where we have to get to know the family and understand the child and see where they're coming from. And that takes time.
And, you know, I'm pretty sure my son would have no memory or idea of why he doesn't like Band-Aids because he was so young. But yeah, he certainly would have some kind of emotional, physical memory. But I'm glad you brought up those points, Taylor. It's too much for us to go into this podcast, but I will refer people to the podcast I did with Dr. Robert Nassif on ambiguous loss, where we talk about parents coming to the realization that they have a child who is different than the child they expected or thought they were going to have. And that certainly comes into play with complex medical cases. If, you know, there were children in my son's wing who had been in a car accident or who had some kind of onset of a disease where, you know, they become paralyzed, or, you know, whatever it is, it was the brain injury rehab unit. So a lot of times this is like going to be permanent disabilities now that the child's experiencing. And that's very traumatic for the parents because your life is now changed. And, you know, if you weren't a full-time caretaker, many of us had to quit our jobs and care for our children full-time, et cetera, et cetera. So yeah, that whole family piece is so important. And I do cover it in other podcasts, and I'll link to that in the blog post. I just want to take a second to acknowledge your pets. We see Erin's cat wandering around, and Taylor mentioned her dog was crawling around there. So hello to the pets if people are watching.
Yes,
on YouTube.
she's very vocal. I'm sorry if you.
They like to make themselves known.
I haven't heard the cat, but I know most people love pets. So I just, for people watching on YouTube and seeing Erin petting the cat as she's walking back and forth. You guys alluded to this, but maybe you can dive in a little bit more, like why this is so important for medically complex children. You alluded to that. Honoring all forms of communication is something that you talk about. Let's dive into that, because you guys are both speech language pathologists, and the whole idea of presuming competence, supporting autonomy, that whole idea of dignity of risk, which is a term I just heard recently. I did a podcast a few weeks ago with Jackie Bartell and Bridget Palmer, another SLP, on presuming competence, with a mother who talked about using different types of spelling board with her son. It was not facilitated communication, although I know it can also be, that's the controversial one with Asha, but just talking about honoring all forms of communication and in this work that you do.
One thing that I see a lot with the medically complex clients that I work with is, especially, I mean, I work with children that spend years in the hospital, whether they're getting a heart transplant, an organ transplant, they are, you know, navigating seizures. There's so many things that can happen, even if it's not years. There's children that for so long don't have control over their environment, don't have control over what happens to them. And we recognize that that is the case sometimes. You know, there's a lot, we're trying to keep them alive. The medical team is trying to save them, but How can we help them feel like they have a control over their environment, feel like they have a say? A big part of trauma-informed care is giving them choices, giving them control, building body autonomy and self-advocacy, which is also really, really important, because we know that children that are medically complex and that have disabilities are more likely to be taken advantage of. So my goal, number one, when I work with a child, is for them to feel confident that they can say no and that they can refuse, and for me to honor that, especially when they have left the hospital. I had a patient that I saw that had a brain tumor that was removed and was coming to see me. And I saw that every time mom and I would talk about something, even if it was just like about the weather, he would shut down. And he had a moment where he was like, all done, all done, all done. We were only 10 minutes in the session. I said, I think we can end for today. That's okay. And mom said, but the session's 45 minutes. I said, he needs to feel like he has control and he has a say. And if we honor that, he's going to be more likely to come back. And so for a lot of medically complex children that we work with too, that may have motor differences that impact their ability to engage with the environment or their ability to communicate with mouth words, we need to make sure that they feel that every way that they communicate is being honored and valued and valid, which is where circles of communication play a huge role from a DIR floor time perspective, because communication starts as an involuntary behavior. When a child is a baby and they splay their arms or they grimace, that's a communication that they may not know why they're doing it. We honor it, we build attachment, we build attunement, and that tells a child what I do with my body controls my environment, and someone's honoring that. And for us to help expand a child's world as well, when they may not be able to engage with it with specific motor differences in the way that they want to, that's when we work together with communication to build off of their ideas, so that something that they imagine, we can work together to grow that, because they deserve to experience the world too in a way that they want to. And I'll let Taylor does a good explanation of autonomy versus independence too, which I think is a really important piece of that.
Yeah, this comes up when we're talking about communication a lot. If we think about a good example is an individual using AAC. If we want them to be super independent without support using a communication system, we might limit what they have access to. So maybe they could on their own access a small grid size, no support needed, they got it, independent. With some support, can they access more vocabulary? Can we have a partner support system? Can we expand on this? If we're not so focused on removing supports and doing things independently. So I think it's an important distinction to make, because autonomy has to do with a person's ability to act based on their intrinsic motivation and their own drive, whereas independence relates to that level of support and resources and the care required for that action. So if we're placing value on autonomy over independence, we can better support a child's confidence, their development of self, have them just have greater access to what they want to say. Because as SLPs, our goal is to help a patient communicate by saying whatever they want to say, when they want to say it, however they want to say it, with whatever supports they need. So we're no longer writing goals for communication without support. Support is not inherently wrong. And with these medically complex cases, we're going to need some supports, and that's okay. Needing a support or an accommodation to accomplish a task is not a diminishing factor. I think knowing who you are and what you need and asking for those resources and supports is powerful. So our goal is to help our kids do that.
How do you help parents presume competence if you kind of see that maybe they're taking over? I'll just give an aside. I don't know if this is exactly the same thing, but if other parents are like I was after my son went through what he went through, you're just so scared of seeing them suffer in any way. You just want to do everything for them and make sure they're totally taken care of. And now that my son is, oh my goodness, turning 15, I realized that I haven't given him that opportunity to be autonomous, because I'm still doing way too much for him and not giving him that dignity of risk. And so I can imagine with medically complex children, that might be a factor as well, with the parents just really wanting to keep them safe and being so concerned with them being taken advantage of, that sometimes you're scared to let them do something on their own, that they might fail or feel clumsy, or you want to protect them from that, but you also have to do that in a safe way.
As in SLP, I don't think I fully understood the magnitude of the impact that how we talk about a child and how we communicate with a caregiver affects that relationship and mental health. So I know Taylor does this too, in our sessions, I'm constantly pointing out the things that I'm seeing that the caregiver, very understandably so, because they're in their own experience of fight, flight, free. When you go, I do not know that experience, but I have worked with a lot of caregivers that have opened up to me a lot about their experience. And yeah, you want to make sure your child is safe. That is the number one goal. And there's going to be PTSD from that experience, and they're on their own journey. And so my goal, and I think about it in the way of like, how am I building this attachment after? How am I pointing out? I worked a lot with Rett syndrome at the last clinic that I worked at. And I remember a mom saying to me, I just want her to say, I love you. I just want her to say, I love you. And I said, and I said to her, I was like, I very much understand that. And that will be a goal for me. But what I want you to also know is, do you see every time she seems stressed, she puts her hand on your leg? Do you notice that she's also saying, I love you in that way? And so it's honoring, I understand, and you have a right to, every caregiver wants to hear their child say, I love you, but I also want you to know that she's also saying it in that way. And so helping caregivers just kind of, our job number one is to understand a child and a family, number one. And I'm spending most of those sessions working to do that. And I think that's also, the fear of a child falling or them, wanting to protect. That's when play is so valuable, because you can make it more fun and kind of release some of that anxiety when we're doing it in a game, or when it's this kind of silly idea that we're engaging together, and we can kind of support caregiver and child in that way. And that's what I love about play, is it allows children to have experiences and learn to navigate that without necessarily having to go through them in the real world yet. They can kind of go through the emotions and feel the safety of that in a place where their anxiety is not as heightened, I guess, in some of those scenarios. And helping them advocate too, because I do hear from a lot of families I work with where people that don't understand will, why does he need this? And why are you doing this for him? And why are you babying him? And why this and why that? And I had a caregiver the other day say to me, she was like, well, I told them, because I know we talked about this, and I told them why he has a feeding tube, because they were like, well, why don't you just make him drink the bottle? And she was like, no, his stomach can't handle it. He has this, and that. And she just giving them the grace and helping them feel that they can advocate for why, and also knowing that, some people aren't going to understand, and that's okay, because it is a different experience for some families. And I even said, so my brother was diagnosed with ADHD. He doesn't have an autism diagnosis, but we have talked a lot about it as a family. And my sister even asked him one day, she's like, Reese, do you think you're autistic? And he's like, I've thought about it. But regardless, he's neurodivergent. And I remember after I started grad school, I went to my mom and I said, I am so sorry. She's like, what do you mean? I was like, I gave you a hard time for what I thought was babying him, and you just knew what he needed. You, as a mom, knew he needed more support. You knew if you didn't sign him up for his college classes, he didn't have the inertia and the executive functioning to do that himself. And I'm so sorry, because I should have known better. And now being in this field, I do know better, but know better, do better. And I had that conversation with her because I was one of those people that was giving her a hard time for just doing what she knew her child needed.
I think that goes back to attunement, and which we talk about all the time in children. Your mom was very attuned to what he needed. And I think we see that a lot with our families and helping them attune to their child is going to also help them give them the independence in the space, because they're going to start to see that they can do it. And another thing I think that, I mean, our clients come out of these very much medical model practices, and they might not know that this could be done another way. We can look at this differently. We don't have to think about this as deficits and supports, and we got to do all these things for them. We can, look at this from a different lens, and Floortime and Trauma Informed Care helps us do that.
And the whole idea of individual differences, so not needing to apply the same pattern to every child, right, which I talked about with Nagwa in the last podcast, in our podcast about cultural differences, where a parent might think I have to treat all my children the same, but instead looking at each individual child sometimes is a new concept for parents coming into this. My favorite part of your presentation in New York, looking through your slides and seeing you focus on medically complex children through the functional, emotional, developmental capacities in the DIR model, I thought was so helpful. Starting with the first, functional, emotional, developmental capacity, self-regulation, and interest in the world.
I have this conversation with families a lot about self-regulation, interest in the world, because it is so, it can change within an hour, especially with a lot of it. It can change within an hour with me. We know this about our experiences and how much sensory input we have and the engagement that we have. But I do find it can be difficult for even me as a clinician, because a lot of the children I work with are very impacted by their medical etiologies. And so, I have a child I work with who has a cardiac condition, and he has differences with his gut. And so if his stomach is bothering him, I'm not going to get the same engagement from him as I would on another day. And it's so important to think about, the environment, our therapeutic presence, what supports we're providing to them. And I will say too, and this is what I talk a lot about with caregivers, we have to learn to trust the children that we work with. Because if a child comes into my session and they're more dysregulated, I am not thinking I need to push them harder. I am thinking, what happened today? What happened today, or what happened this week that I'm seeing a different child? Because this is information. And I can't tell you the amount of times that a child comes into a session with me and something's a little off. Their energy's a little bit lower. They seem a little more dysregulated. Their attention to me isn't what it usually is. And the next day they're sick. And I'll say to family, this is if we need to end the session early, I'm going to work with where this child is right now. And I'm not going to expect that they're going to show up to my session the way that they left it last time. That's not fair for any of us to be expected that in any of our relationships. And so we also, I think that's a big piece of regulation, but I think another big piece of regulation that we have to think about, especially from a sensory difference perspective, is a lot of medically complex children are lower arousal because they have motor differences or experiences. My kids that have cardiac conditions, they fatigue really quickly. So they don't have as much opportunity to engage with the world in the way that some of their peers may. And what that means is that they're not having as much of those sensory experiences. But that doesn't mean they don't deserve them. And that doesn't mean that we shouldn't work to help them have those experiences, because regulation does not mean calm. Regulation means my body is ready to engage with the task that I want it to engage with. And so many of our kids, oh, this kid's so low arousal, they're so chill, but they may want to do something where they need maybe some higher arousal and maybe need to help them upregulate. But what that requires is trust, because so many people touched their body if they were in a medical setting when they maybe didn't want them to. So how do I build trust first? Because they may need more tactile support. They may need some of that to be able to have those sensory experiences. And so I'm not going to go right there and put them on a swing and give them some vestibular input. I'm going to build some positive touch, see what their reaction is to it, and help build that as well. But just like with any of us, like we talked about, it's not linear. So regulation is always going to be a component for all the children we work with. But those are just some considerations to think about too when you're working with that specific population.
And for people that were at the New York City conference and saw the presentation on regulation with Gretchen Kamke and Amy Lewis OTs, I will be doing a podcast at some point with about that with Gretchen, maybe with Gretchen and Amy, I'm not sure yet, but they talked about this adaptation window, which is sort of a new way of looking at regulation from neuroscience and from other research that's come out where, a child that, like you just said, regulation is not necessarily calm, but say a child looks calm, one could be completely over aroused even though they look calm, and one could be under aroused even though they look calm, and every child's at a different state, and then that whole adaptation, and I'm sure I'm not describing it as accurately as I should be, but just that idea that someone who might have in the past, like I've always considered my son a sensory seeker, and we're moving away from that language now because he might be a sensory seeker in these particular conditions, in those particular adaptation window areas, whatever, but not other times. In other times, he's overstimulated by things. And everybody has all of that built into them in differing degrees. Like I think Virginia described it as the VU meter on, like, if anyone knows those old radio station boards where you can adjust all the levels of everything at the radio station. I used to be a college radio DJ, so you'd like move all the levels up and down. Each individual difference of each child is, like they need more of this, they need less of this, and then it changes, and it's all so dynamic. So I hear you. Some days I'll notice like my son is just off, and then sure enough, he gets sick the next day. Or an hour later, he has a bowel movement. And, our children may have those interoceptive awareness of something going on, but don't necessarily communicate it, or they might not have that awareness at all. Therefore, they can't communicate it either. So just getting to the place where my son is like I said, almost 15. Just now he's able to say my stomach hurts. Like he never used to be able to say that. And then at that point I have to guess, like, is it because he ate an hour ago and he's gonna have a bowel movement? Is it because of something that he ate didn't sit right? Like, what is it? So these can be big issues that impact regulation for sure.
And the amount of times the amount of conversations I have with physicians as well, where a child has a feeding tube or they just had a certain surgery and the doctor will say, well, this shouldn't bother, like they'll say to the caregiver, well, this shouldn't bother them. It's just the tube in their nose. Like it's not really. And certain children, as we know, have different sensory systems, and it's going to impact them differently. And that's when I encourage caregivers to say, and advocate for their child and what they need, that they may be responding to something different than another child, but it from a medical model, that can be tricky for some providers to understand, because in their mind, the anatomy's fixed. We're good. Like this is fixing it. And so it's just helping them understand that regulation piece and that interoception piece and that sensory piece, which can be really tricky, but it's trusting. And okay, I promise this is the last story before Taylor talks, but I had a patient that she would point to her leg. She just kept pointing to her leg, and mom said, something's wrong. And the doctor said, everything looks fine. She's like, something is wrong. My daughter is pointing to her leg. They did an x-ray. One leg was longer than the other. And so it was very uncomfortable for her to walk. And it's because that mom trusted her daughter and that communication of pointing and said, something is wrong. And it built this daughter's beautiful self-advocacy for all these other things, because she had a lot of medical complexities. And I love that story, because that mom knew that she knew her child and was like, even if I'm wrong, I'm advocating for her. And she wasn't, because I will tell you, moms usually are not wrong.
I love that story. I'm glad you brought it up.
When we talk about engaging and relating with these medically complex kids, we want to keep in mind that the way that a child might seek love, connection, attention in this FEDC, it may look different due to their individual differences. So they might not have the capacity to reach for a caregiver in the same way, to move their body closer to someone, to hold eye gaze, to tell someone my leg hurts. So this is again where we're attuning to their unique communication style and their way of relating with others. And we get back to that total communication approach. And we're thinking about, how is this specific child in this interaction right now, given whatever supports they need, how are they with me? How are they lighting up with excitement? Or what are the subtle cues that I'm picking up? When we're new to a case, I always like to have these conversations with parents early. What does it look like when they're engaging with you? When you feel the most connected with your child, what does that look like? How does that feel? What are their cues? If a child is not speaking or has motor limitations, hearing or vision is impacted, what are the cues there? Is their body getting stiff with excitement, or are they frustrated? Is that vocalization content vocalization, or are they scared? If we have these conversations with parents and we're attuned to what's happening, we're present enough, we can start to read these cues and then be present in this capacity in a more meaningful way. And that's why this is specifically in this capacity, we want to really focus on following their lead, setting aside our agenda and looking at what's meaningful and relevant to this child. With these medically complex kids, we want to really enter their world instead of pulling them into ours. So this is where that great engagement and intimacy occurs, when it's their idea and it's not forced upon them, and we might need to support them to get there, while still maintaining that autonomy and while building those positive relationships.
And always easier said than done, of course.
Yeah.
In the presentation, you guys did show case studies, which we can't do on the podcast, but I imagine that is helpful when people hear like the examples, see the examples.
Mm-hmm. Because I think it's also, I mean, that's why I love the DIR floor time training, because you really get to see so many things that are so hard to describe. And that's, I think the in this engagement piece too, it's giving caregivers permission, because they know their child, but from a trauma-informed lens too, you have to acknowledge that there's been, you know, especially when a child is in the hospital, you don't have that much control, unfortunately, because the medical team is making a lot of decisions. Yes, you know, if you want to be a part of those decisions, you can be there at rounds, but I can't, you know, I have a hard enough time as a clinician speaking up to a doctor. So I cannot imagine how it must feel to be speaking up to a doctor as a caregiver that maybe doesn't have the same health literacy that I do. And so acknowledging that and helping caregivers start to trust their gut again, and start to just be with their child and feel connected, and know that our goal is to help you feel as connected as possible. That's really, really the most important thing throughout all of these FEDCs. But I think once a caregiver understands and trusts that that's your goal as well, it helps them kind of drop a little bit of a wall, setting your own ego aside as a clinician as well, that like there may be some walls up, and they may, you know, I don't take things personally from any of the caregivers I work with, because I know that they're not, and that they, you know, there may be times where I'm not the best fit, but for the most part, they're coming in, showing up in the best way that they can that day. And so how do we help them, you know, and help give them grace too? There are going to be days where it's going to be hard to get on your child's level, and that's okay. That's life. Karen Purvis talks about how if you try to say as many yeses in a day, because the more yeses you say, the less the no can cause trauma to a child. And I will encourage caregivers to say, how many times do you say no in a day that you maybe don't realize? Like, how many no's are we giving this child that we just don't realize it? And how many choices are we making for them that we don't know? Because there are times where we may not know that. I use the example of, I do a lot of feeding therapy. So if maybe I'm giving this child a blue spoon every time we eat because it's the spoon I have. And they're always offering the blue spoon. Then all of a sudden I decide, I have a red spoon or a blue spoon. Which one do you want to pick? And they pick the red spoon. And maybe they pick the red spoon because they have a cortical vision impairment and we didn't know, and they can see red better. But without giving more opportunity for choices, we're giving less opportunity to learn about the child, because who knows, they may have those opinions and have just been never given the option. And so I think from a intentionality and two-way communication, when we're looking at FEDC2, FEDC3, FEDC3 TOO is where I was going with that. But it's so important to acknowledge every communication effort that is being made, even if it may not seem purposeful, because that's how we build the understanding of communication. Like I said, with babies, when I work with NICU babies, I tell them, I'm teaching you how to communicate with your child more so than I'm teaching you to feed them. This is building your attachment and attunement. And we have to know the way a child communicates each day may change. I work with a lot of children that they only use their communication device when they're in unfamiliar environments, when they have more anxiety, when they're in more pain, because it's harder to access that symbolic language. Language is very complex. It's a lot of symbols. And I do tell caregivers too, we use less language oftentimes with the people we love the most, because they understand us. So sometimes, caregivers will say, well, they don't use their communication device at home, or they don't tell me as much at home. And it's because they feel understood and seen, and they've spent all day trying to be understood by people that aren't their typical communication partners, and it's exhausting. So sometimes you just want to get home and lay on your head on your partner's shoulder, or just touch their leg, or communicate in those ways, because you feel safe regardless. Less language doesn't mean less safety. Sometimes it means more. And we need to give caregivers permission to communicate in any way their child wants to when they're at home, and not always feel like they have to be pushing more language. Because I think as SLPs, we think, okay, you're working at home. Home is where they feel the most comfortable. Let's work on this, this, and this. When in reality, some of that is the opposite, because that's where you can build some more of that connection. Language doesn't always expand connection. Sometimes it does, but this purposeful, or this intentionality and two-way communication is where we can start to build the trust. It'll move into FEDC4, but I'm thinking about a client specifically who I remember he would come to our sessions with an idea every day. And one day, and this is my favorite story, I guess I have a lot of favorite stories, so maybe I'm lying, but he came one day with a piece of paper, just a piece of paper. And it took us 45 minutes, but we got to the point where he had the paper with his head in the middle and then two pieces of paper on his feet. And he hopped around and he goes, boop, because he was the Pixar lamb. He had this idea to be the Pixar lamb, but because we had built this intentionality, purposeful two-way communication, he trusted that we spent 45 minutes going back and forth with communication to build this idea that leads into is FEDC4, but it was because of how much time we spent in FEDC3 building trust, that no matter how I communicate with you, I know you're going to figure it out. And that was really, really important and very cool.
It made me think of this example, which is not directly related, but related to that idea of communication. It just happened last weekend. So I met up with another parent from ICDL's parent support group that I facilitate at a water park, and I don't do water slides. So that they brought another person who was going to do the water slide with my son. And so I was watching all of the stuff, and they went to go to the water slide. So, a few hours later, the other mother tells me that when they went to go on the water slide, and this is a park that my son hadn't been to since before COVID. So he had been many, many times before and was familiar with it, but hasn't been for a while. And it was this other family's first time there. So the mother and the friend who brought the kids to the water slide didn't know anything. They were just sort of following my son. And she said something very interesting to me. She said, he knew that we had to go stand in line to get a raft. As people come down the slide, they pass their raft to the people, and then you go up the stairs to the slide. But he didn't go out of his way to tell me. So she said he knew what to do, but he didn't communicate that to me. So I was sort of confused as to what we were doing. But then when she asked questions, he would answer like, oh, do we have to stand here and get the raft? And he'd say yes or whatever. And I shared that story with Jackie Bartell, who's been on the podcast a bunch of times. And she said, do you think that that might be because these kids are being guided and told what to do every minute of every day? And they're so guided by the adults that they don't need to say what they're doing because the adults just bring them and do stuff. And I thought that is so interesting that I haven't thought about that before. And it's making me think more intentionally about wondering with my son about next steps so that he gets the practice communicating what he's doing. So it made me think of that when you were talking about FEDC 3.
Yeah. Yeah, I love that. And how, go ahead, Taylor.
I was thinking about a lot of my kids in the classroom, like I go into school sometimes and they'll just get up from the table and go do whatever they're doing. And teachers are like, you need to tell us what you're doing. But to have that thought of like, I made a choice, now I need to let you know. Like, it just might not occur to them in that moment. They have their own idea. What is the purpose of telling you? Like you said, when I'm just so often just going along with the flow as well.
Yeah, and I was really excited that I was happy that the mother shared that with me, that she even noticed that to point it out, because that's probably something that I wouldn't have noticed about another person's child. But she's a teacher, so she did notice that about my son. So anyway, that was a cool learning experience. And I guess that leads us into the fourth capacity. And like, I just harping on that point that the FEDCs aren't linear. Like typically you're you're aiming for all of these at once. So if the child's regulated, you're getting engagement and back and forth communication, which leads to social and shared problem solving anyway. It's not like, oh, let's get regulated. Oh, okay, now we're regulated. Let's get engaged. Okay, now we're engaged. Let's communicate. Like it all happens at once and it just sort of flows, and then you might get dysregulated and you're trying to co-regulate again. But it's all sort of happening together. And you described that nicely, Erin, when you talked about FEDC 3 and you said you're sort of getting to that point of, with the child, the Pixar, what was it, Lamb? Where it got to the point where you were actually shared problem solving together. So do you want to, who's doing FEDC 4?
That's Taylor.
Talked a lot about sharing ideas, and this is really in this part where we talked about how we want to give choices and how there's so much potential for building autonomy in FEDC 4 when our communication circles are growing because we're regulated, because we're engaged, because we're having that intentionality. We're expressing more ideas, creativity is flowing. So there's so much happening. And this is where I was also thinking about, Erin, you talked a lot about choices and how so often for these kids, they're going through their life and they don't really have a lot of opportunities for choices. Like you said, we've decided so much for them throughout their day. So to find moments in our play where we can give them that opportunity to expand and grow, we're following their lead, but how can we model expansion and take them a little further, stretch their capability here. And we also want to go back to like, are they able to communicate their ideas here? How are they communicating them? Always circling back to making sure we're tuned into those more subtle cues that we might have to look out for. But by now we know what their interests are. We're connected, we're tuned in, and we can model. How can we help them show us their ideas and build on them? And Erin makes a good point. Maybe you want to elaborate on this more about how we might not know what we want our body to do or what our idea is if we haven't exactly experienced it yet. So bridging that gap to help a child get there.
Yeah, I had a child I used for a case study, and He has Down syndrome, has a feeding tube, has cardiac condition, obstructive sleep apnea, has had a lot of hospital stays for getting sick, and mom is amazing. And he really loves vestibular input. But he needs support from mom to get the amount of vestibular input that he wants. So it's a really great example of, he loves the song Row, Row Your Boat. So they built this beautiful social routine where they sing that song together. And at first they would sing it, and then mom kind of moved his arms a little bit, and then she started to see him rock back a little bit more. And so she kind of guided him a little bit and helped him so he could rock, because if he tried to rock back as much as he wanted to, he would fall and bang his head, which is not safe. So they built this trust and routine and back and forth to help him experience more of that input that he loves so much, but needed that connection piece to feel someone that he trusted to support his body to do that. And it's, again, to presuming competence in so many ways. Because, and I think too, this is where communication devices are really helpful as well, because, I'll have children I work with who find something on a device, and even sometimes I'll be like, I wonder where that came from. And oftentimes it's something they've seen, it's something they want to experience, even if it's just something they are interested in. I'm going to honor that and either show you a video of it, or, I do a lot of feeding therapy, and I'll have a lot of caregivers say, well, he mentioned broccoli and I just don't think he's going to want to eat broccoli. That's nowhere near anything he's ever wanted. But I'll say, why don't you try it? See what happens. Try it. And how many times has that child eaten it because they saw it on a show with a character that they trusted that ate it, or they saw, something that interested them and sparked their idea of, what is this? Let me experience this. So just because they can't go, like, another child may see the broccoli on a caregiver's plate, grab it, put it in their mouth. That's another child's way of doing that. They just don't have the motor capacity at that point. And I'm sure a lot of people that listen to this podcast follow PlaySpark, who I love. And Serena, who's the SLP of PlaySpark, her son Rudy, who she talks a lot about. I love the video she posted where, he's just turned 1, but he was less than 1, and he has a motorized wheelchair or a motorized scooter that he uses. And she said, how beautiful is it that at less than a year, he can take himself to that shelf and knock down books on the cabinet, because any other, another child his age that doesn't have, what he has can do that. She should be able to do that. But sometimes we forget about those experiences as well. Like, he should be able to get in a little bit of trouble for knocking the books down too. Like, that's an experience that maybe he wouldn't have had she not presumed competence in him being able to navigate that situation.
Well, you guys have shared so much information. I thank you guys so much for being here. I want to let listeners and viewers know that if they want more information, I'm sharing, for those that are listening on audio, on the video, I'm sharing the website for Erin's podcast that she does with a fellow SLP called First Bite, and I'll put the link to this in the blog post. And if you scroll down to the bottom, they do have courses, audio courses, and they will go into this stuff in a lot more detail, along with other topics that you can see here. So I'll put the link to that. Taylor, have you been on the podcast as well with them?
I have.
Yes, I made her.
It was great. We did an episode on mentorship. Erin was my mentor, and so we talked a little bit about our relationship.
Hopefully people will tune into that as well.
I have a course coming out on trauma-informed feeding therapy, and the focus really is, how do you build your authentic therapeutic use of self to do feeding therapy that feels good? Because so often the type of feeding therapy that has been promoted and that has been more behavioral, it shouldn't feel good, and it doesn't feel good. So how do we support families and clients and families to help make mealtime more positive and safe?
Thank you guys for what you do.
Thank you for having us. We really appreciate it. It's been wonderful.
Until next time, here's to choosing play and experiencing joy every day. Caregivers, I facilitate the International Council on Development and Learning's weekly parent support meetings every Monday at 1 p.m. Eastern Time and monthly on Thursday evenings at 9 p.m. Eastern. Let us support you in finding the connection and joy with your child as you support their developmental process using DIR. See the events menu at affectautism.com or the Parents tab at icdl.com/parents.